afternoon, everyone, and thank you so much for giving me this opportunity to raise my voice regarding how I feel about as a clinician who treat brain cancer and GI cancer. I'm a consultant clinical oncologist working in University Hospital Plymouth NHS Trust. Despite all these disturbances, I appreciate that you guys are carrying on this session. Congratulations for the sessions today.
You saw what happened midway, which is
I know.
yeah,
I know.
happens.
The trauma, I mean, still I couldn't get rid of the trauma. So let me quickly take you through what I wanted to convey the message, because this is the Brain Cancer Awareness Month. I don't know whether anyone's aware of that, which is so unfortunate. This is what has happened to brain cancer. So in next 10 minutes, I'm going to take you through like eye-opener about where are we in terms of brain cancer management. So if you think of this history, like back in Hippocrates era, where they didn't have brain surgeries, but they did burr holes to get rid of symptoms. And the first primary brain tumor resection done back in 1884 in UK. Since then we have like massive increase in technology advancement in neuronavigation surgery and the imaging techniques. But why I wanted to raise my voice in this pathology summit, where I feel that in treatment and in histopathology or it has not parallelly increased the way that we see in the other tumors. So GBM, as everyone knows, is challenging, and when you look at the classification of brain tumors, you may see more than 100 primary brain tumors. But our challenge is the high-grade glial tumors, where like when patient, it's when if you think of a patient with a brain tumor, you would think even a slight headache, it's unbearable. So then how can a patient present very late with a brain tumor, yet it's not fully understood the mechanism? And some patients do present with very large tumors. They lived more than months before we get to know this tumor, before we diagnose it. So are we doing the correct thing for brain tumor management? So we are in the era of neuronavigation, where the surgeons can go, like unlike the olden era, they reach the deeper tumors with awake surgeries and can get the maximum tumor bulk or the proper tumor sample for histopathologists to assess. And on the other hand, we have very advanced technology in imaging, like MR spectrometry, where you can clearly like see what's going on, what function, so without affecting functionality, neurosurgeons would be able to resect the maximum debulking and then send patient for us to do chemoradiotherapy or the treatment. But as clinicians, we are helpless. As you can see here, like 9 out of 10 children with leukemia now survive. 9 out of 10 breast cancers will survive. However, unfortunately, brain cancer, still, if we compare what we had the treatment options 3 decades ago, still we have the same, despite all this advanced technology, immune therapy, targeted therapy. Where are we? Even we can't, like, it's incurable still. So a lot to, like, I feel why I wanted to raise my voice, because there are patients when I like break the bad news that you won't survive more than 3 months. Young patients, fit patients, they ask, can I get into any clinical trial that is ongoing? And we do have in NHS the only Cancer Research UK. But I feel if there are research anywhere in the world, ongoing, and to try and link these patients to get involved with the clinical trials, where most of the patients are very happy to, like, they know that they are dying. At least they want future human beings to have proper treatment. They are ready to be an experiment. On the contrary, I realized that recently um, there was a global summit where the most of the laboratory workers, that they find hard to get clinical, like get patency for clinical trials. So there's an obvious barrier where there are hardworking group which do a lot of clinical trials. So in terms of these molecular markers, I'm not going to strain your brain to explain all these molecular markers, because I know the audience is not very well, like brain specific audience, but we do have few specific tumor markers and genes which was available only like for last 30 years, which no new improvements and no new treatment options for brain cancer management. So what I wanted to emphasize during this session for everyone, that there are patients who are happy to get into clinical trials. If anyone have information, kindly let us know, that we need to bridge the gap between these people who do hard work in the laboratory level, that they find it very difficult to get in to human trials. On the other hand, there are dying patients who wants to get into clinical trials. So somewhere globally, so now its world is a village, and we should not stick to our treatment area or what we have. I feel it's our duty and responsibility to step out beyond the borders and help these suffering group, especially I feel brain cancer patients, no matter whether they're diagnosed elderly, young, or middle age, the chances of survival is very remote. So that's what I wanted to, like, open your eyes on this brain cancer survival month, that we need to do a lot in terms of brain cancer survival. Thank you so much for listening.